Ladies and gentlemen, good afternoon. I would like to welcome you in this clinical seminar series meeting of HIAAD, the Hellenic Initiative Against Alzheimer's, which has both research and educational goals. I'm Dardiotis Themis, Associate Professor of Neurology at the University Hospital of Larissa and head of the local Alzheimer's daycare unit. And I'm very honored by the HIAAD to coordinate this session. So I'm very pleased to introduce Tracy Vannorsdall, Associate Professor of Psychiatry and Behavioral Sciences in the Division of Medical Psychology and in the Richman Family Precision Medicine Center of Excellence in Alzheimer's Disease at the Johns Hopkins University. Professor Vannorsdall is going to tell us about the post-acute neuropsychiatric sequelae of COVID-19. Professor, the floor is yours.
Thank you so much. Can everyone see my slides?
Yes.
Perfect. Well, thank you for having me. I appreciate the invitation. So when we think about post-acute consequences of SARS-CoV-2 infection, it's important to keep in mind, first and foremost, that we don't have a unified definition of PASC or post-acute sequelae of SARS-CoV-2. The WHO tells us that it's a lack of return to one's usual state of health following acute infection. And it can include the onset of new symptoms, and these symptoms can vary over time. They can remit and reoccur later on, which makes it a very challenging phenomenon to study. By their definition, these symptoms are present for 4 or more weeks after infection. And it's been estimated that there will be over 15 million cases of this long COVID worldwide. And on average, these patients are in their 40s, most generally. So this is really affecting individuals who are at the prime of their life and their level of functioning. As we talk later in my discussion, we'll be speaking specifically about the elderly and how COVID is a particular risk in that population. But when we think about it more broadly, we do think that it's going to be affecting a large number of individuals really in the prime of their life. And when we think longitudinally about the trajectory, we see that symptoms under other definitions, PASC or long COVID starts more likely around 12 weeks following acute illness. And we see multiple organ systems that are affected 12 weeks out and persisting. There's increased incidence of mental health burden, certainly of healthcare utilization, and 10 to 30% of patients are experiencing these persistent symptoms, quite often related to fatigue. And so of the studies that have followed patients longitudinally, and these are primarily studies that are starting in China and following the disease as it progresses around the world. The data are sort of tracking there. And when we look at patients who have been followed out 6 months after their hospitalization, we're seeing that 76% of patients are still reporting at least one symptom that they associate with their COVID illness, most commonly fatigue or muscle weakness. But we're seeing a fifth or nearly a quarter who are reporting substantial difficulties with their emotional well-being. This is also the case when you follow these folks even longer, to the point of 1 year. We're seeing about half of patients continuing to report at least one symptom. Again, fatigue seems to be that symptom that remains the most persistent. And about a quarter of patients are continuing to experience symptoms of anxiety and depression post-illness. There are a number of proposed mechanisms. This slide shows 3 potential mechanisms that we could consider. Those are respiratory and systemic disease, direct invasion of the nervous system, and post-infectious immune-mediated complications, right? So we can think about multi-organ failure, sepsis, critical care syndrome, and PICS, or post-intensive care syndrome, acute respiratory distress. And then there's also the possibility of coagulation disorders, encephalitis, stroke, and a number of different mechanisms by which cognitive and emotional well-being may be affected. This is simply an updated paper talking about the potential mechanisms for affecting brain health. And I think it's important to note that there is certainly thought to be an inflammatory process, and levels of immune activation have been found to directly correlate with the degree of cognitive and behavioral changes that we're seeing post-COVID. This is certainly a novel coronavirus, and there's a lot we need to learn about it. At the start of the pandemic, we really had two sources of knowledge that we could draw upon, and those were the cognitive and psychiatric symptoms seen following prior coronaviruses, as well as the critical illness literature and what it can tell us about what our patients are likely to experience. And certainly it's now well appreciated that the neuropsychiatric symptoms are really key following COVID illness for many patients. When we look at the SARS and MERS outbreaks of about a decade plus, we see elevated rates of anxiety, concentration and memory difficulties, depressed mood in many of these patients, although these are relatively small studies and they aren't necessarily designed to assess these psychiatric and cognitive changes in depth, but they do certainly point to a role for the coronavirus infection in these outcomes. And then the critical illness literature is another place that's been extremely helpful in guiding our thinking about potential neuropsychiatric outcomes. So we are seeing a lot of folks who require care in the ICU. And as many of these critically ill patients experience acute respiratory distress syndrome and require mechanical ventilation. And so these have consequences, downstream consequences for the patient, as well as for their family members, as one can imagine. And as it relates specifically to COVID-19, there are a number of obvious physical changes that we would expect. We're seeing that patients have substantial cognitive difficulties as well associated with their ICU stay, because this is what we see in ICU patients more broadly, not necessarily specific to COVID-19. And then there are major psychological consequences, and we'll unpack that here in a moment. But what I think is fairly unique to COVID-19 when it comes to ICU stays and psychological impacts is the stigma and the fear associated with the illness. Many patients are reporting guilt because they feel they brought COVID into their home, their loved ones became ill. They're, certainly at the height of the pandemic here in the States, there were real concerns about spreading to other people and people being leery of other individuals' sort of cautiousness regarding COVID prevention strategies. And so there's a lot of sort of emotional weight to having a COVID illness and to getting quite sick. There's also a lot of media coverage that can really heighten the fear and concern regarding COVID-19. And what we see cognitively after critical illness is that a large minority of patients will have persistent cognitive deficits. So here are data from a multi-center prospective cohort that enrolled patients who had an ICU stay due to respiratory failure or shock, and they were administered the R-bands, which is a global test of cognitive functioning, as well as some other tests of executive skills at 3 months and 12 months after their hospital discharge. And what they found is that at 3 months after discharge, a quarter, and persisting for a full year out, around a quarter of patients are performing below the second percentile compared to where we would expect them to be for someone of their age. And this occurred regardless of how old patients were. So our elderly patients were having cognitive difficulties that persisted, as did our younger individuals. And what we know is that delirium predicts worse cognitive and executive functioning in this patient group. Additionally, when we look at ICU and critical illness patients, data from here at Hopkins and our collaborator, Ann Parker, show elevated rates of post-traumatic stress symptoms that can persist a full year or longer after the acute illness. We see a similar elevation in rates of depression in ICU survivors, with about 30% showing prolonged mood symptoms lasting a year or more. Particularly those who are in ICU for longer periods of time. And we believe that depression predicts long-term cognitive difficulties in this group, and depression in particular. So post-traumatic stress symptoms don't seem to be predictive of later cognitive difficulties, but mood symptoms do. So it really highlights the need for mental health and cognitive services sort of throughout the trajectory of acute illness and the post-acute phase in our patients who have required an ICU stay. So we're seeing major rates of psychiatric symptoms. And when we translate this over to the COVID pandemic, we're seeing similar issues with mental health difficulties. So this is a large electronic medical record network cohort study of 69 million individuals, over 62,000 of whom were diagnosed with COVID-19. And the primary outcome was the incidence of a first psychiatric diagnosis within the first 90 days after a COVID-19 diagnosis. And they controlled for all of the relevant risk factors for COVID-19 and severity of illness, and compared the likelihood of a new psychiatric diagnosis to 6 other health conditions, things like the flu, upper respiratory infections, fractures, etc. And what they found was that a diagnosis of COVID was associated with more first diagnoses of psychiatric illness compared to all of the other 6 health events. So here in our figure to the right, in blue along the top, we see upper respiratory infections, with that pinkish red being COVID, showing elevated rates of psychiatric difficulties, depression and anxiety. And then on the bottom, we're seeing a similar relationship for upper respiratory infections. So clearly there's something about COVID that seems to stand out as it relates to the onset of new psychiatric symptoms, particularly anxiety and depression, as well as sleep difficulties. Additionally, if you broaden the outcome to include any psychiatric diagnosis, including a reemergence or a relapse of an existing psychiatric condition, we're seeing that a substantial increase associated with a COVID illness relative to these other types of health conditions. And this is occurring even in non-hospitalized patients. So it isn't specific to having an illness that is that is so severe that is requiring hospitalization, which I think is really important for us to keep in mind, because disentangling sort of the important variables, is it hospitalization and the acute illness severity? Are these outcomes seen across the trajectory of COVID illness severity? I think those are things that we're really still trying to unpack. And these data would suggest that psychiatric symptoms occur in both our acutely ill and our ambulatory patients. When we try to expand this to think about assessing cognition post-COVID, there are a number of challenges at this point. Certainly one is that there's a great deal of variability in symptom presentation across patients. The trajectory of cognitive and other symptoms post-COVID is variable. By definition, according to the WHO definition, the symptoms may come and go at different times. And so when we measure, when we assess is going to be important, because we need to have these longitudinal sort of careful assessments over time of various symptoms. And any cognitive and neuropsychiatric symptoms are going to be occurring against a backdrop of the general pandemic-related stress, social isolation that was going on early on, that really heightened distress levels for individuals, regardless of whether they were personally affected by COVID-19. Additionally, and this is clearly the experience we're having here at Hopkins, is that we are seeing a lot of patients with COVID-19 illness who had not been in the medical system. They didn't see their primary care doctors, or they didn't have one. And so there's a real possibility of unmasking comorbidities that had previously gone undiagnosed, that might not necessarily be associated with their COVID illness. They may be exacerbated by their COVID illness, but there's a lot to sort of disentangle there. And then, of course, we need to figure out, what is the effect of the virus, treatments that patients are receiving, et cetera. Currently, our cognitive outcomes, they still remain fairly limited. We do have more data now than we did 6 months ago. But it's still the case that many of our studies are focused on fairly homogeneous patient groups. This is both with respect to demographic characteristics as well as with respect to COVID severity. And the demographic characteristics are really crucial, particularly in the US. We realize that racial and ethnic minority groups have been disproportionately impacted by the pandemic, and they appear to be at higher risk of poor clinical outcomes. And so it's really important that we are including really diverse samples in our research studies that really capture the diversity of our existing sort of population. Additionally, much of the cognitive data, as you would imagine, is been captured thus far on sort of captive patients. They're in the hospital, they're recovering in a post-acute facility. And so we're getting them really early on in their recovery process. And so these just by definition, these longer term outcomes are going to take a while for us to collect those data. And that's in the works, but certainly it's the case that we have a lot more data currently on how people are doing acutely and not so much in that post-acute phase. And then the actual cognitive assessment batteries are going to be really important. Early on, we have many case series, lots of studies on cognitive screening tools like the Mini-Mental and the MoCA, which might not give us enough sensitivity, or very focused batteries that are specifically looking at one specific type of cognitive domain, or focused on subjective patient reports. Those are sort of the low-hanging fruit, the easiest data to collect. And so that's what much of the body of literature has been thus far. But we are slowly moving to larger samples of objective cognitive data. And there's a growing appreciation that we really need to be thinking about how we want to measure cognition carefully, as well as other outcomes, depression, anxiety, olfaction, and other functional outcomes in our COVID patients. And so the Neuro-COVID International Neuropsychology Task Force, which is associated with the International Neuropsychological Society, they've put together a harmonized battery for use in clinical and research studies aimed at helping sort of give the field a more concise way of thinking about which tools are appropriate. And they're really looking at tools that have been well validated in multiple populations. They've been used in different languages. There are well-developed training manuals. They have good psychometric properties. And so for those who are really focused on sort of the detailed look at how to assess cognition, there is some guidance that has since been published. And there have been some objective cognitive studies that have been published. And this is a review that came out in July, and it's already certainly outdated in many ways, right? Because the data are coming out so quickly. But they explored 12 articles that included fewer than 1,000 patients. They excluded anyone with direct neurological complications like a stroke, delirium, people who already had mild cognitive impairment or dementia, right? And these are studies that tested patients anywhere from days after symptom onset to 6 months after hospital discharge. So it's really a big range. Patients varied in terms of their severity of acute illness, from very mild to ICU, requiring an ICU stays. Additionally, many of the sort of domain scores that were examined were really just breaking down the MoCA screening measure into its component parts. So not necessarily full cognitive tests. But what they found is that there were very high rates, in all 12 studies, global cognitive dysfunction was present, as were deficits in attention and executive functioning, depending on how that was defined. The majority of studies also demonstrated difficulties with memory, verbal fluency, and with about half showed some visual spatial difficulties, but visual spatial functioning is not assessed very frequently in these studies. And so what they concluded is that patients post-COVID tend to experience global cognitive difficulties and problems with the attention, executive functioning, and verbal fluency in general that may persist. So at this point, what's really needed are comprehensive, objective neuropsychological assessments that are designed to help us identify the prevalence and nature of cognitive difficulties, as well as psychiatric symptoms and functional decline. We need to be doing that in diverse patients, as I mentioned, and we need to be doing this outside of that acute phase of illness, when patients are sort of getting back to their regular lives and so that we can get a better sense of where we need to intervene. And so with that, I'll introduce our Hopkins PACT team. So this is the post-acute COVID-19 team. It is led by Ann Parker and Alba Azola, and previously by Emily Brigham. This is one of the nation's first dedicated post-COVID clinics here in the US. It was established in April of 2020, really built on Ann Parker and others' work in the post-intensive care syndrome sort of framework. And it's a multidisciplinary clinic. It's really led by pulmonary and critical care medicine, as well as physical medicine and rehab and Johns Hopkins home care, with a number of different collaborators. It's very much a multidisciplinary team. We meet weekly to discuss patients and their needs. This was originally a fully virtual clinic, and it's now moved to a hybrid model now that the pandemic has slowed down a bit here. And so our clinic serves patients who required care in the ICU, as well as patients who do not require ICU care. So some of them may have been seen in the hospital or required hospitalization, but didn't end up in the ICU. Others remained fully ambulatory throughout their illness. And so at this point, there have been more than 800 patients seen through the PACT clinic. More than 300 of them have undergone cognitive testing, maybe 350, and I'll tell you a bit about those data here in a moment. A little more than half were admitted to the ICU, but I think that proportion is trending down. Their average age is in the mid-50s, and this really has just been consistent across the course of the pandemic. And consistent with the Baltimore sort of catchment area, our patients are majority minority. And so what we wanted to do is early on get a good sense of what types of cognitive difficulties and neuropsychiatric problems our patients might be facing and experiencing. And so as part of the PACT clinic, at the time of each patient's first follow-up visit, which for us is on average about 4 months after their acute illness, they receive a clinical phone call from one of our team members, and they undergo a cognitive test battery and complete symptom questionnaires over the phone. We selected our battery. It's derived from the multi-ethnic study of atherosclerosis and the NAC uniform data set. And it was selected so that we could administer it in English and Spanish. These are all validated tools for telephone administration. And we chose a telephone route of administration because we wanted to make sure that we were not going to be missing out on some of our most vulnerable patients. And so many of our lower income patients and our non-native English speakers don't have access to Zoom or to Wi-Fi, that they're not being charged by the minute. They would not be interested in spending some of their internet time on calls with us, and many of them don't have access to that. So for financial reasons, and so that we could get a good, clear sense from our entire community, we chose to go with a phone battery, and it really does seem to be working quite well. And so we were assessing patients' new learning and memory, their processing speed, their executive functioning, attention, working memory, and their verbal fluency. And we were defining impairment relative to their performance compared to other people their age. So we're using published normative data. We don't have a non-infected control group because these first data were collected in spring of 2020. We were still in the height of the pandemic, and that just wasn't feasible or safe to start recruiting people for additional studies. But we're defining mild or moderate impairment as performing less than the 7th percentile relative to one's age group, and severe impairment is less than the 2nd percentile. We're also looking at rates of clinically relevant symptoms of depression and anxiety. Post-traumatic stress symptoms were assessed specifically in those individuals who required an ICU stay. And then we're also looking at functional decline with the Quick Dementia Rating Scale. Right? And so, like I said, we've seen about 350 patients for baseline testing right now. I'm just going to show you our first 82 English speakers. I'll just highlight our demographic characteristics for both our ICU and our non-ICU patients are pretty consistent with our PACT demographics overall. Patients are on average 54. We have slightly more women than men in this sample, again, majority minority. And from a cognitive standpoint, it's important to be thinking about things like education and estimated IQ. Is this sample sort of following that normal distribution that we would expect? And our patients are bright and well-educated. So the average IQ is about 100, and they have on average about 14 years of education across both clinics. We do see that our patients who required an ICU stay are a bit older and had slightly fewer years of education and slightly lower IQ, although those are still solidly average. And so these are our outcomes. We're looking at these 8 cognitive domains as well as this cognitive composite that you see on the right. And for all of these age-adjusted scores, lower scores reflect poorer performance. And so what we see is that for the majority of the scores, we're seeing the performances below that red line. They're performing more poorly than we would expect. The dark blue lines show our ICU patients. And so we're seeing more severe cognitive deficit ICU versus non-ICU patients. And we're seeing a similar pattern, though, that sort of stair step with notable deficits in verbal fluency, processing speed, as well as learning and memory. Where we're not seeing deficits, interestingly, are in just sort of simple attention. Our patients seem to be doing quite well there. And here's just another way of showing these data and really demonstrating that 2/3 of our patients are producing at least one mild to moderately impaired score across this battery of 8 tests. And these are elevated rates relative to what we would expect for a test battery of this length. In terms of just general rates of impairment, we're seeing the same, very similar rates of impairment among patients who required ICU care and those who did not. Certainly, we're having 15 to 30% of patients scoring in the impaired range on 2 or more tests. Really indicates that these are notable and clinically meaningful cognitive difficulties that our patients are experiencing. Additionally, more than 3/4 of patients are reporting at least one elevated psychiatric symptom, with more than 1/3 reporting moderate or clinically significant elevations on at least one measure of depression, anxiety, trauma, or trauma-related distress. Now, I will note that our depression measure taps in quite heavily to things like fatigue and sleep difficulties, and so that may be inflated by that those symptoms being included. And may not reflect sort of the core sadness and anhedonia and lack of motivation that we often see and think of in sort of classic depression. And we're also seeing really high rates of functional decline. And what I think is important to think about here is that our functional decline measure, the QDRS, is very heavily weighted to changes in daily functioning related to changes in mood, as well as changes in cognition. So we think that these cognitive difficulties and these mood difficulties are really translating into problems with patients' everyday life. And notably, cognitive outcomes and mental health outcomes were not correlated with one another. And we also didn't see differences in psychiatric outcomes based on the type of whether somebody needed ICU care or not. So regardless of sort of the severity of illness or the intensity of treatment that's required, we're seeing similar levels of emotional distress. So the take home for us really is that these symptoms are persisting in our patients, that we need to be measuring them in order to be able to detect which patients are experiencing or continuing to struggle with their cognitive and mental health following their illness. But we're seeing high rates of multi-domain cognitive deficits. We're seeing it across the illness and treatment spectrum, and it's impacting our patients' functioning. And I think that brings us back to the importance of these multidisciplinary teams and having folks there who can help address those symptoms as they arise. And so within our clinic, we're meeting weekly. We're talking about each of these patients as they come up. And if they're screening to show difficulties with their cognition or their mental health, they're being referred to Hopkins psychiatrists, to neuropsychologists, to rehab psychologists, so that we are sort of linking them into the care that they need. In terms of the specific interventions for COVID, from a more behavioral perspective, we don't really have much by way of COVID-specific intervention research at this point. but we can certainly rely on interventions that we know have demonstrated efficacy in other sort of patient groups. And we think that those are helpful. There is some data to suggest that simple psychoeducational materials may be helpful in alleviating cognitive and emotional dysfunction, specifically following COVID. So those were our, so when patients get referred to us, I showed you sort of the pathway. They come to us, we see them for clinical services, and we provide our normal standard of care. We've also been talking with our colleagues internationally to see if we're seeing similar types of cognitive difficulties. And so we got together and shared data on 88 clinically referred patients across 4 sites, 3 in the US, 1 in Europe, and covering 3 languages, and looking 7 months post-illness at the outcomes for our patients. All of them were reporting cognitive difficulties. That's how they got to our clinic, but we're still seeing high rates of fatigue, sleep difficulties, and self-reported emotional dysfunction in these patients as well. Again, processing speed, to some degree executive functioning, and here attention and working memory tended to be more notably affected, but there's a lot of variability. And what I think is really notable as well is that a fair proportion of patients, nearly half or more, were reporting 7 months out that they were unable to, pardon me, return to their work at their baseline capacity. And so again, just sort of speaking to how this affects patients in their everyday lives. So I want to sort of transition and think about how we understand COVID and its effects on aging populations. Because as I said, most of the average age of our COVID patients who are coming into our clinic, it's really mid-50s. But that means we still have a very substantial portion who are elderly. And what we know is that absent an actual infection, the data show, particularly early in the pandemic, that our older patients, patients with mild cognitive impairment and dementia, and their caregivers were experiencing significant declines or reporting significant patient declines in their communicative performances, their mood, their movement, their compliance with new instructions. Patients were, caregivers were saying that they were more difficult to sort of manage and their flow was disrupted due to the pandemic and pandemic-related restrictions. And that was perhaps translating into these elevated caregiver reports of physical and mental health burden. So we know that this is sort of a vulnerable population. When we think about elderly patients who have experienced COVID infection or COVID illness, we have really nice data show of more than 1,500 patients who are 60 plus, with a control group of uninfected spouses who are assessed 6 months after hospital discharge. And their cognitive testing was the TICS, which is a telephone-based cognitive screener, a more elaborate screener certainly. And they're looking at cognitive decline over time as rated by an informant, and that's captured by the IQ code. And so what they found was that compared with the non-infected spousal controls, COVID patients had lower cognitive scores and higher scores on that measure of cognitive decline. Patients who were more severely ill also had lower scores and greater cognitive decline than those who were less ill and relative to those who didn't, or their control cases. COVID severity, delirium, and having COPD were all risk factors for current cognitive impairment. And then longitudinal decline, a change in cognition or a steeper change in cognition, was more likely among patients of lower educational attainment, those who had more severe COVID illness, those who had delirium, and those who had various medical comorbidities like high blood pressure and COPD. And so we're seeing that our elderly patients are having persistent cognitive difficulties, similar to what we're seeing in our younger patients, certainly. And then it's clear that our patients with dementia are an at-risk group and a group that we really need to be paying attention to. There are nice data demonstrating that they're at elevated risk of becoming infected with SARS-CoV-2. Their cognitive compromise is likely impacting their ability to engage in those adherence strategies, or I'm sorry, to adhere to protective strategies like wearing masks and social distancing. And what's been found is that patients with dementia overall are at 2 times the risk of contracting COVID. And this seems to be particularly elevated among those with vascular dementia, which really suggests that their already compromised vascular system may be playing an etiologic role in that manifestation of neuropsychiatric outcomes, or at least the becoming ill with COVID-19. We're also seeing it more frequently in younger onset dementia patients and in Alzheimer's disease. And of course, we know that patients with dementia are experiencing poor outcome following their COVID-19. They're more likely to be hospitalized, more likely to be in the ICU, and they're more likely to succumb to their illness. And there's also data showing that those with an ApoE4 genotype have increased risk of hospitalization in particular. And this may be linked, or it's hypothesized to be linked to inflammation and cytokine production. So we really need to be paying attention to the short and long-term impact of COVID-19 on the elderly. And so I will just wrap up. I wanted to make sure we had sort of plenty of time for discussion and just note sort of how we're going to be addressing this here within the Johns Hopkins PACT Clinic. Esther O, one of our collaborators, has obtained funding to follow our PACT patients as well as non-COVID hospitalized elderly patients for 12 months. So we're going to be taking our baseline cognitive data that we're assessing, reassessing them with that same battery at 6 months and 12 months, really with the goal of determining the baseline clinical factors like medical comorbidities and demographic characteristics, as well as blood biomarkers, particularly levels of inflammation that may predict ICU delirium and poor cognition related to that ICU delirium. And so with that, I will sort of, there's a huge team associated with all of our the work here in the PACT Clinic and the Precision Medicine Center. I'm just touching on a few folks, but there are many, many folks who are really, really important here. And I'll leave us with the PACT Clinic website, and I'm happy to answer any questions that folks have.
Professor Vannorsdall, thank you very much for your excellent speech and for presenting us your data. It seems that COVID-19 symptoms are very common. They involve most organs, and with regard to the CNS, we have high frequencies of cognitive difficulties, anxiety, depression. These symptoms persist, variate, and they implicate a lot of pathophysiology. We're open to questions and comments.
So if I could, I'll lead off. Tracy, great job. Thank you. As always, really nicely done. I'm actually trying to put some of these findings in the broader context. You touched upon it a little bit of psychological symptom complaints after chronic illness. You talked about what I might define as biologic mechanisms, but what about psychologic mechanisms that might contribute to the chronicity of symptoms? Obviously, touching on a risky area, these are very disabling symptoms, and it's not the question here. But the question is whether this has, at least in some people, very little to do with COVID biology, but rather have more to do with a person who was exposed to the severe chronic illness who is now emerging from it.
I think that's a really good point. Just the vast number of individuals who have been infected with, who have had COVID, implies that we're going to have patients who have some proportion of our post-COVID patients are going to be those who have a natural propensity to focus on their health and physical well-being, and have difficulty sort of shifting away from the patient role. And I think we're going to see some of that will certainly come into play. We have a subset of patients who have identified as post-COVID who were ill before we had objective testing to be able to document that. And that really challenges our thinking clinically, as well as from a research perspective in terms of who we think about allowing into studies. And there's certainly a patient group and patient advocacy groups that are really concerned that that group will be marginalized or disregarded. But we do know, and there are good data out of Chicago, for example, showing that in their post-COVID clinic, they had, the vast majority were women, and I believe 42% had pre-existing symptoms or diagnoses of depression. And so this may also really be sort of a vulnerable group in terms of individuals who are likely to experience persistent symptoms post-COVID. And I think that the treatment for that group of individuals may be fairly different from the treatment of other patients. Remains to be seen.
Any other comment or question?
Can I ask you something?
Yeah.
My name is Jan Zaganas. I'm a neurologist. So thank you very much. That was a very nice presentation. And what do you think about the future when this is going to become, let's say, an illness? Many people think it will be recurring like the influenza. So do you think there's a parallel with infections like influenza or other infections that have become chronic?
There may be. I mean, I think it's really hard to say what's going to happen with the pandemic more broadly. If we just consider the millions of people who have been infected already, we know that and who are reporting persistent symptoms, we have our hands full just sort of managing and understanding those individuals. But it does sound like, my appreciation of the literature is that this is something we're going to be living with respect to new infections, and hopefully there will be treatments that minimize the severity of those infections. And our hope would be that means that the neuropsychiatric symptoms will not be as prevalent or severe. But I think that just considering the folks that have already, started reporting persistent post-COVID symptoms, there's going to be a lot for us to unpack and manage in the years to come. And we're thinking also about, my colleagues bringing up interesting data. I'm really focused on adults, but certainly what this means for our pediatric populations, for pregnancy, and for offspring who were born to mothers who experienced COVID during their pregnancy. There's sort of lifespan perspectives that come into play on both ends of the spectrum.
So we need to think about the role of an infection in the neuropsychiatric symptoms of our patients. So let's say if they have a recent infection, we should take it into account when we examine them in a memory clinic or in a setting like that.
Certainly clinically, I've started asking all my patients whether they've had COVID, and if so, sort of to tell me about their trajectory and the treatments that they received. And so now it's sort of standard part of my clinical practice.
Also, if they have been vaccinated, this is also a standard question nowadays.
Yep, no question.
I was reflecting on this issue with some colleagues yesterday. So certainly in Baltimore and the States, we've had millions of people infected. We've had probably millions of people through ICUs and so forth with COVID. So if the cognitive disability post-COVID was substantial and sustained, I would be expecting that memory clinics would be getting a lot of referrals for these patients. We're not. We've seen very few in our memory center, very few folks post-COVID. In fact, the first case I saw was just last week. So for me, there's still a bit of a disconnect. And I don't know, Tracy, if you have any thoughts about that. Are they getting care elsewhere? What's happening? If the numbers are so big, why are they not knocking at my door all the time?
Yeah, I think that's a great point. And there is, our clinic is set up so that if they have sort of pure cognitive issues, they come to me. If they have cognitive and mental health issues, they often are being seen by a different group within Hopkins, our PM and our rehab psychologists, who are really focusing more on the emotional well-being and tackling the emotional changes first, with the notion that we'll see once we get mental health symptoms under control, that might be a better time to really re-examine the persistence of any cognitive difficulties. But you're right, I do think that if we think about the different rates of sort of cognitive difficulties that we're seeing in the published literature, it's not translating into what's walking in the door from a clinical perspective.
Maybe other symptoms may prevail. For example, fatigue.
Yeah, that is a great point. I think that many of our patients who are still sort of looped into the medical system, specifically because of their past or post-acute COVID symptoms, the majority have fatigue. They have a lot of pulmonary issues. They're getting PT or OT, and they're being seen by a number of specialists. And it may simply be that while those are being addressed, some of these other mental health and cognitive issues are not being targeted yet.
Any other comment? I don't see any question in the chat. Professor Kertsos, would you like to wrap up?
Oh, thank you, Professor Dardiotis. Of course, it's always a pleasure to have Dr. Vannorsdall present these data. She has done a wonderful job taking the lead for us at Hopkins in these issues. It's an evolving field. There's a strong hint that lots of folks have chronic disabling symptoms after COVID. We still don't know why they do and who's got it, why, how much is infection, how much is severe chronic illness, how much is pre-existing factors in vulnerable people. All of this will get sorted out. But I think we're off to a very good start in trying to understand these. As you heard, Tracy has studied close to 350 people. She already has a paper in press on this. And I think the next stage now will be going to the 350 people, trying to understand more broadly what's going on. But great job. Most grateful to have everybody attend. This is a recorded conference so that people can go see it or pass it on to other colleagues. Thanks for allowing me to comment.
And thank you all of you for being with us. Maybe next meeting will be on the next year. So we'll learn more about the Hellenic Initiative Against Alzheimer's Disease. Thank you, all of you.
Bye-bye. Thank you.
Bye-bye.